Thanks. It's nice to be here. I'm Ted's counterpart at Seattle Children's. I have a few things to disclose. We have intellectual property with the insurance industry related to what Ted talked about. Everything I said, though, I'll say though, I am representing Seattle Children's, and Plugs is Seattle Children's. It's not a separate company or anything like that. I wanted to acknowledge the Department of Pediatrics at the University of Utah, Ted, and a bunch of people for inviting me. ARUP is our biggest collaborator on some of the Plugs collaborations that I'm going to talk about, and Intermountain Health is a member, and I see Jim Gudgeon's here. So, and I get down to Utah a lot. My daughter lives in Mount Pleasant, so and I'm the only person from New Jersey usually in Mount Pleasant when I'm there. But actually, I've come to really enjoy it. We get down quite a bit, and I also want to thank my team in the UW. So I'm going to talk about value. Then I'm going to talk about some of the uses and abuses that are found in looking at large insurance claims databases. I'll talk about interventions to improve test ordering. And then I'll talk about Plugs, which started out as the Pediatric Lab Utilization Guidance Service, and now we have 2 trademarks because we actually have more than 50% of the members now are adult health systems. More than half of pediatrics is actually practiced in predominantly adult health systems, but it turns out the interventions for improving test ordering, retrieval, and interpretation are the same for adults and kids, and there's a lot of overlap in the abuses. For example, everybody wanting celiac testing and being afraid to eat bread. It afflicts both, and really, if you want to understand test utilization, all you really have to understand is celiac disease, because it's both the most overused and underused test at the same time. So it's both the most overdiagnosed and underdiagnosed disease. So there's a lot of overlap with pediatrics. So lab stewardship, we used to call it lab utilization management, but when people hear the word lab utilization management, they think, oh, I'm not going to get my claim paid. I'm going to have to talk to someone, I'm going to get a no. Lab stewardship is really a better term, and it's caught on, and it follows on the heels of the antimicrobial stewardship movement, and it's about managing a scarce but important entity, in a hospital system, which is the lab. And lab stewardship just seeks to get rid of all the crazy tests. And as I'll show you, there's actually quite a bit of fraud. All the tests that are put online before they're ready. Frank quackery, these are tests like nutrition tests, trace elements, people thinking they've been poisoned when they haven't been. People who have various kinds of fears brought about by things like the wellness movement, which ironically makes everybody sick when it comes to lab testing. It's fine to jog and do yoga and all that stuff is all great, and eating right, of course, who's going to be against it. But when you go, there's really no tests to order in well people. There's very few tests to order in well people, and so what happens is you order a bunch of stuff, and then you become very fearful and withdrawn. And then other things about lab stewardship is it has a big focus on genetic testing, because that's the most misordered test in the United States. About a third of genetic tests are ordered is an incorrect order. About 5 or 6% are actually frank medical errors. And actually ARUP, Chris Miller and a bunch of people at ARUP, they were really on the forefront of starting this movement to put lab genetic counselors between the order, to look at each order and correct them. And then lab stewardship helps with misinterpretation of tests. And obviously this has benefits. When you don't test, you save money for both the patient or the lab if it's a patient who can't pay, and it gets rid of a lot of unnecessary work, because nobody likes to do a test that's not necessary. No lab people like to see the lab clogged up with a bunch of vitamin Ds that aren't necessary while there's an emergency hemorrhage panel coming down the pike. So value is quality over cost, and we define it as the quality of what the patient gets divided by their cost out of pocket. When the patient can't pay, then the lab pays, which means all patients pay. In my department, 98% of the money we get is derived from a patient, either through their insurance company or directly. And now in the era of high deductible insurance, a lot of our patients, our average family of 4 in our county, which is considered a wealthy county, King County, in Washington make $75,000, and we're talking about genetic tests that can be $3,000, $4,000, $5,000, and they're out of pocket for it, either because of high deductible or because it's not a covered benefit. Now, we've studied insurance data claims databases as part of some large grants with Evercore Health, but there's a lot of databases out there that are either publicly available or that can be studied with, just in collaboration with either commercial insurers or the government, who's here to help. And the Medicare database is searchable. And one of the craziest things about searching is that a normal person can actually search the Medicare database. I'm going to show you, you don't need like a big data analyst to search the Medicare database. One of the better databases out there to search is Optum Labs, and there's a lot. I'll show you a few studies from Optum Labs, but that's a collaboration between Mayo, United Health, several other companies. And the thing that makes it better than insurance claims itself, insurance claims don't have much information on them, but this combines it with the electronic medical record, and you can get some great studies. Our biggest studies were done on very large databases, first in 2008 and 9, and then more recently. And these are large databases, over 3 million in the first database, and about 2.5 in the second. You're talking about $500 million of insurance claims for the year. The whole laboratory industry is only about 72 billion. And I think ARIP is most of that. Am I right, Brian? I think it's one of the. It's a big lab. And anyway, so this represents a very statistically robust sampling of the entire industry across most of the states of the country. And what I'm going to try to summarize, 12 years of work in 4 slides, but I just divide up all the findings into things that are just a little bit off, tiny bit shocking, but I can live with, versus things that are amazingly shocking, and I can't even believe the kind of stuff that goes on. So on the tiny bit shocking side are just where you order like an older test instead of a newer one. You order a T3 resin uptake instead of a modern, test. Underused tests like not ordering a anti-cyclic citrullonated peptide in the workup of rheumatoid arthritis, just ordering an RF. Suboptimal coding, you didn't do it on purpose, but it's a little off, it's not fraudulent. Or workups that are just a little too big. Like most at a time, a celiac disease workup you can do with a couple of tests, an IgA and an anti-tissue transglutaminase. But some places bundle 5 tests. So that's not great, but it's a little bit shocking. Now on the shocking side, there's I'll show you a few examples, but we're talking about pure magic, tests that are always positive. There are labs that do Lyme disease testing that only produce positives, nutrition disease testing. Everybody is deficient. Testing for stealth viruses and odd critter balances in your gut, etc. Then there's completely obsolete tests like ordering a bleeding time. Frankly, fraudulent CPT coding to just get money, and then mega workups, especially around toxicology. These are workups of 40 or 50 CPT codes, $3,000–$4,000 in a relatively well setting. So there's a fair amount of data now accumulating on the stuff that's not so shocking. These are just 4 studies that were published just from the Optum database, and in the one on the bottom, SED rates and CRPs are ordered together too frequently. Factor V Leiden above that ordered too frequently relative to protein C resistance. So I won't go through them all, but these are just the small things that accumulate. And if you tweak in your practice, you'll be better off. And a lot of places do that. And you can use sources like Choosing Wisely as one source of making some modest tweaks in your practice. Now, on the shocking stuff, I want to show you a few things. So MTHFR is a completely useless test, and Choosing Wisely has a nice thing like don't order MTHFR testing. So I thought I would, and we've banned it. You can't order it in our place, and naturopaths really like it. And in Washington, there's a lot of naturopaths. So that's an issue for us, is dealing with their ordering practices. And I thought, well, do people still order this? So I went to the Medicare database. So remember, this is in adults, it's a big issue in kids. And I looked, I searched the Medicare database in 2014 was what was available, and there was $14 million spent on this test, 239,000 tests from about as many patients from 130 labs. And look at the names of the labs that were the leaders and from building the government, and you've never heard of any of those labs. And if you've heard of any of them, it's the first one, which is a lab that's extremely famous for fraud, which was revealed by the Wall Street Journal in a series of articles and ended up going out of business. It was cardiovascular disease risk lab, but they test anything. They would just test everything. So these are there's one of these labs associated with racketeering and organized crime, and this is the kind of thing you see. Now, more interesting is, so that's just frankly shocking. And then this is a little bit more interesting because it has some nuance to it, but this is allergy testing. So the normal test for an allergy workup would be an allergen-specific IgE, is kind of the foundation, plus an regular total IgE. But IgG allergy testing, which is in choosing wisely, in which there's tremendous, amount of information and guidance out there not to use it, especially in food allergy testing, represented from this large claims 14.5%. And this is really favored by naturopaths. And then the ALCAT, which is Frank Quackery, was 6%. I can't even remember what it stands for. Very famous quack test. You got 21% of the U.S. spend on quackery in allergy. Who's paying for that? You are. It's in your per member. It's when you pay your insurance company. That's what you're paying for. You're paying for this kind of waste. And then even amongst, and then who does IgG allergy testing? I looked at Medicare database, and there's 1.92 million of IgG allergen, and almost one lab, which is a famous lab for wellness and this kind of thing. So they are doing well with the U.S. government. Who's paying for that? The taxpayer pays for that. And of more interest to me is, what about normal testing like allergen-specific IgE? Well, this particular graph shows the number of units that were ordered in one workup. So whether it's inhalational or food, which is the most popular, or venoms or birds, whatever, and you can see that over 37% of the workups are greater than 20 allergens. And for almost all these workups that you look at recommendations, 15 or less allergens are recommended. And in fact, usually 10 allergens or less are recommended. So the size of the regular workups are also too large. The most shocking thing and the most fraudulent is urine toxicology, which I renamed shoxicology after looking at the data. And now there's tons and tons of lawsuits. But every kind, if you were teaching lab management and just wanted to show every fraud that's out there, you would look at urine toxicology testing, which is about 7% now of lab testing in the United States. And about 30% of it is totally unnecessary, and a huge percentage of it is fraud. So there's these companies set up either small labs in a strip mall, or they set up sober houses where they pay people to come in and pee in cups, and then they run every test under the sun, especially if they can get blood. They'll run genetic tests and vitamin D, and then of course all the pain and opioid and all the big drug panels as well. Thousands of dollars per workup, sometimes twice a day. It's so bad that Cigna, which is one of the largest insurance companies in America, left Florida because Florida, which was the worst state for it, couldn't control it. But it's in all 50 states. The physicians are bribed. And so now there's a tremendous pushback, both by the government in the terms of the way they allow the coding, as well as insurance companies. The biggest lawsuit is one in Texas with United Healthcare suing for $100 million of false claims. That's a lot of false claims. And that's just lab, pee in a cup type stuff. So I can keep going through all these examples, but I'll summarize everything we've learned over, and that's been what I think's been published for the last 10 years. That these are the 9 areas of laboratory, the domains of problems in laboratory. It doesn't represent them all perfectly, but in pediatrics, there's an overlap between adults and pediatrics. Wellness testing driven by the Googlification of healthcare, and then the sharing. So Google lets you get a lot of bad information very quickly, and then social media allows you to spread it so that everybody thinks that their headache is due to the fact that the painter came or someone put fertilizer on their lawn or something like that. And it's the reason why there's so many people on restricted diets, because everybody's sharing their crazy diet. And those people are also not fun to go out with. Because they're like, I wouldn't eat that. I'm like, well, I'm eating it, and I'm not inviting you out again. Flow cytometry, the workups are too large. You start with a 30-cell marker bundle when you need, say, 10 or 12. Allergy, I mentioned. Autoantibodies, especially around overbundling and celiac disease. or over-testing of HLA and celiac disease, genetic testing, which I'm going to talk a lot about, and inpatients, which is really just too many daily labs. And especially, it's a big issue in pediatrics because of, iatrogenic anemia. It's not a small thing. So you don't want to take, take blood from all these tiny kids. So now I'm going to talk about interventions that are part of stewardship systems that are in health systems like Intermountain to improve utilization. And these are not hard to understand, but they're difficult to do. And in general, that's what if someone asked me, Mike, explain anything in quality improvement in laboratory services, I would say difficult, easy to understand, difficult to do. You don't need all these lean consultants and all these crazy consultants coming in with their big words and actionable insights and big data. This stuff is easy to understand, but it's hard to do. And I'll talk a little bit about what can happen when you do it, which is good. We focus the interventions on the care providers. I think it's great to educate patients. It's great to keep pharmaceutical companies out of the hospital and labs, commercial labs out of the hospital if they're pressuring individual docs to overorder. But the real intervention comes from creating a system with your care providers. And the weakest things, you're not doing lab utilization well or stewardship well if all you're doing is sending memos to each other, telling each other to be more careful, and you're just doing trainings. Because I don't know how many more papers we need to show that training is a weak intervention for utilization. If you want to get rid of bleeding times in a system, don't have a continuing education about it. Just take it off the menu, then have a continuing education about what you did. And the continuing education is called, these are all the things we just took off the menu and why, instead of trying to convince people. And that's my main point, is that it has to be structural. You have to make structural changes in the system, and that takes teamwork and collegiality and collaboration and review of the literature, et cetera. So these are all the interventions in stewardship, and they vary from gentle to strong. And you'll see on the strong side are things like privileging, like only a geneticist can order. I'll show you an example, a rapid exome in our, a rapid exome on an ICU patient is an example of that. Send outs formulary, so you're just forbidding. We have whole labs that are forbidden. Either a lab itself, or a lab test is forbidden. Hard stops, which everybody hates. I'll show you actually a slide that Brian gave me, or that I developed with him, about hard versus soft stop. And then, of course, the requirement for higher level collaboration. And the best example right now that's being used by a lot of children's hospitals is when you order genetic tests, you get contacted by a lab genetic counselor to help you. And it's a collaboration. It's not a coming down on you hard or whatever. And then the medium strength interventions are usually around templating. Make it easy to order the right thing, hard to order the wrong thing. Like in CPOE templates for the ICU, for example, would have certain tests. For primary care, you wouldn't see rare genetic tests on a primary. You'd see 25 common tests on a primary care CPOE template. And then soft stops would be in the middle. This is where Dr. Jackson is here, but he wrote a nice article about nudging in ClinLab News. And the idea is that physicians, when you look at IT interventions, everybody hates a hard stop, and every physician is trying to click through it, but you can't do it, and they're just saying, I hate practicing here so much, and and soft stops, they just override. But soft stops can be helpful because even if they override them 50% of the time, the other 50% of the time, a lot in there is a lot of correction and improvement going on. So even an incremental gain, it doesn't have to be perfect. Templates people like because it makes it easy to order the right thing. Report cards with positive reinforcement where you say, hey, this is what you're ordering, and this is what you're all ordering in whatever clinic, say endocrine, and you're like, look at this person, look at this, look at this, look at Evelyn Simpson over here, she's amazing. Look at the way she orders, and you try to move people to towards a person who's behaving according to the guidelines you've created, rather than just saying, look at you, you're all a bunch of idiots. This ordering is crazy. Look at these report cards. I'm ashamed of you. So the idea, I can't even believe nudging won a Nobel Prize because it seems obvious that people like good news. But anyway, he won a Nobel Prize. But it works to try to be more positive and make stewardship less about coming hard on people and just trying to collaborate and create these templates and ordering systems together with the experts. Computerized reminders, they work. I mean, these are various soft stops or hard stops that you can see. The one on the bottom is one I just invented, that kind of a candid camera thing. And then changes to manual requisitions. You're probably still receiving paper. If you're a reference lab for any outside specimens, you're still receiving paper. We still receive about 5 to 10% of our stuff on paper. And the key to paper requisitions is to get rid of all the obsolete tests, a few of which I list here. And then it's really important to go find the old requisitions and destroy them. Because people will keep requisitions for like 20 years if it has their favorite tests on them. We once convened at the university a little task force to get, how are we going to convince them to get rid of their old requisitions, And I'm like, let's cancel this meeting. Let's get some baseball bats and let's head up there because we know where they're keeping them. We know who is submitting these old orders. Let's get up there. Let's get them and shred them. And when you do that, you can get an effective intervention. Now, I talked a little bit about this already, the idea of don't put rare tests on a primary care requisition. The requisition is very important in terms of what people order. I'm going to show you an example of that with vitamin 125D in a minute. This is a good example of the structural changes. Jeff Baird and Wayne Chandler and colleagues at the University Hospital wanted to reduce ionized calcium ordering. They had looked at it, and there was a lot of uselessness going on. It was driving a lot of calcium therapy that was unnecessary. And in the period between January and November of that year at 2 hospitals, they did a series of educational interventions, and you can see that the ionized calcium does nothing. I'm not saying it was useless because, there's collegiality and you're setting people up for the big structural intervention which occurred around January, which is they changed the definition of an ionized calcium to a total calcium and ran it on a big robot. And ionized calcium was only run if you were privileged or if the total calcium was out in a certain way. And you can see that's a structural change that led to a dramatic decrease in ionized calcium. And similar things have been done to get rid of CKMB testing or decrease it a lot in chest pain workups, et cetera, both in pediatrics and in adults. Now at our hospital, this is how we do stewardship. I'm showing it to you not because it's the way to do it, but it's illustrative. And if I look at the various hospitals we interact with now, this is pretty common. So we have a stewardship committee that meets once weekly, Tuesdays at 10 o'clock. You can actually call into it. I think Jim Gudgeon has called into it. And we have genetic counselors, various kinds of faculty there, and from our department and from other departments. And it's great that we have geneticists participating, and it's important in a children's hospital. And then we have subcommittees that meet ad hoc. So we have an exome subcommittee that meets once a month to go over all the exome cases. We have a committee that have formed around specific areas of GI test ordering, led by the GI faculty. That met for a short period of time. They did their work and we're done. Then we have a hospital stewardship committee that meets quarterly. This is when you can't solve things at a local level. Like if you have certain physicians and they want to order these, say for example, large cancer genomic profiles that are more research oriented, you could bring a controversy, something you don't want to settle yourself, to the stewardship committee. So we like to bring things especially that are like proprietary tests. Any test that has a fancy name I worry about. And it says TM after it. So we bring that to the stewardship committee. And then we record all our cases in a database so that when a new case comes in, we match it to how it was decided with an older case, because that can be very helpful to decide things consistently, which is really important in a stewardship program. So our key components is we review every genetic test case and every case where we've said a test is being misordered a lot, so we flag it for review. These tend to be expensive tests. And we work on interventions to reduce duplicates. That's fundamental. And then we do a lot of policy making around, especially around genetic tests, but other tests as well. This is what is formally reviewed. All genetic tests, request to use a lab that is either on the banned list or isn't our chosen lab for a send out, or certain tests that are just done all under management because they're just ordered incorrectly quite a bit. Like reverse T3, there's very little indication for. Here's some of this. We can produce a much larger list of the tests of shame, and But the providers really like that we've gotten rid of these, because a lot of these are driven by patients who've read something, and it's really nice for our providers when they could say, you know, you can't have it here. You can get it through your naturopath or whatever, but you can't have it here because you know, we don't have it on the menu. And then to ban a test, we get a consensus, we write a policy and procedure, and then we communicate it to the staff. So that's been very popular. I want to show you how requisitions and just sound-alikes can drive incorrect test ordering very innocently, and this has happened all across the United States, but 1,25-dihydroxyvitamin D is not used very frequently, and it's not the nutritional status test. And we were just sending out a lot of these, and we found on chart review that the intended test was 25D, the nutritional status test, 68% of the time. And so we designed a IT intervention and to change the name of 125D to the, like, I don't know what we're going to call it, like the one you don't order versus vitamin D, the one you order. But we had to line up on the IT flight plan, but that flight doesn't take off. It turns out if you try to do IT stuff, you got to get in a line, and they say, just get on the flight plan. I'm like, can I get a seat on the flight? No. What does it cost? $1 billion. Can I sit in the bathroom? No. Can I be in the luggage? No. So we designed an email intervention, and the email intervention was like, you order a 125, we send you like a super nice note that says you may have made a boo-boo. We don't mean to say anything by it, but it's frequent boo-boo. Do you want to change it, or do you want to continue with the order? And sure enough, this is what happens. You can see the 125 orders in that bluish green. You know, those are the send-outs. They start to go down when the intervention, we start to cancel a lot of tests, and it goes down when you do this. And people love this intervention. They were sending only in pediatrics. In adults, you'll never get a thank you note in stewardship. But in pediatrics, people were like, thanks. So that worked out really good. And then later we got off the queue and were able to change the names of the tests so that people could order them correctly. Genetic counseling is really, it's really the foundation of any stewardship program in a pediatric hospital. And this was work, I mentioned Chris Miller from ARUP. But, you know, about a third of genetic tests are ordered incorrectly in the US, and that varies from frank medical errors through just minor tweaks to improve the test. And now there's a whole literature on it, including stuff we've published, Cleveland Clinic, et cetera. And we review all genetic test orders, and I'm going to summarize a few years of doing this. We reviewed over 6,000 test orders. We started a pre-auth program a little ways into it, so now every test has to be pre-auth. That's great. We try to get that done within 1 day, or 2 days if it's a weekend. And in our system, about 22% of the orders are modified using this lab genetic counselor-based intervention. And that's led to $1.4 million in cost avoidance for either the wrong test or tests that would have been ordered incorrectly, or tests that were not needed, for example, because they were duplicates. And half of that money comes back to us because half of our patients can't pay, and that's great for the lab and pays for the whole system. And then half goes back into patients' pockets. And one of the biggest complaints patients have now is because of the high deductibles, or because genetic tests are often not a covered benefit, is high out of pocket. Now, just to show you how this is just one thing that came out of the genetics work. So there's all the pre-auth work and all its correction of errors by lab genetic counselors working with geneticists and pathologists. But then a subgroup formed of geneticists who wanted to do inpatient genomic testing correctly. Before this project, called the Right Project, I'll actually cut to the chase. Before this project, there was no rhyme or reason for when people ordered this. Sometimes it helped, sometimes it didn't, but there was no rigor to it. There was no inclusion criteria, and there was no support from genetic counselors. So findings would come in that were very confusing for patients and their families, and there's no genetic counselor there to help explain it. So there's just no standard process. So this was a quote from a geneticist that basically was saying, I need help with consenting. So we formed, this is what stewardship can do. It makes people think in an organized fashion, develop inclusion criteria. And so a group of geneticists formed a committee and a process using genetic counselors that you get a consult from genetics from the ICU. It quickly goes to this committee that's available. They make a decision within 24 hours, and then we order a rapid exome if they approve. And they don't approve every one. And then counseling, it comes with a basket of genetic counseling services for the family. And just to make a long story short, it really works. This is actually the first 15 patients. It helped in 2/3 of them. A typical case would be, the cases that it helps, it falls into a couple of categories. In one case, like one kid, they ended up having genetic disease of calcification, and so it changed their therapy to bisphosphonates, and there was a bunch of things that were going to be done that were avoided, and they pressed hard on therapy. With other kids, and that kid did well, and we got a diagnosis for it. There are other kids though where they come back and you have a fatal disease, and so they withdraw ECMO, which is a big deal, because sometimes we keep kids on ECMO for weeks and weeks on end. And it's not just it's not just expensive. It's very, very difficult to watch and be part of. It's extremely difficult for families. So to be able to withdraw care in a way where they feel they have closure is an extremely meaningful result. So this, I won't go through all the cases, but it turns out if you use these inclusion criteria, you get a very nice result, and then sometimes the geneticists say you don't need an exome. You need, in one case, the kid just needed a seizure panel, which we ended up getting back in a couple of weeks, and the kid did fine. So before the Right Project, it was a mess, and after the Right Project, things are going well, and now we can do it as a continuous improvement project. Working with the ICU, we're going to now liberalize a little bit the inclusion criteria to see if there's some more kids we can capture and help. So I won't go through all the words there. So a long story short, we do this for a few years or a couple of years, and things are going well. And a lot of people in pediatrics who work in lab were complaining about this problem of stewardship, especially around genetic tests, that they're ordering tests, they're not getting paid for. Many labs were under financial pressure. What could be done about it? And so at the Children's Hospital Association meeting in 2012, a bunch of us were out for dinner, and I had this idea that we were just kind of working around the table. It's like, let's form a network. Actually, I called it a co-op at the time. We actually called the group PLUMP, the Pediatric Laboratory Utilization Management Cooperative, which was a dumb name, I was told pretty quickly. And then Rob Carpenter, who's now with ARUP, but at the time was the direct lab administrative director at Children's of Colorado, said, let's call it PLUGS, Patient-Centered Lab Utilization Guidance Service, and we'll all share our tips, tricks, policies, procedures, alignment with the insurance companies, how we're doing it. And I said, okay, we'll quarterback it. So over the next 6 months, we cooked up a way to make memberships and a place that everybody could put their documents, and start to do conference calls and member meetings, and it took off. And so I'll cut to sort of 4 years later, we have this PLUGS, which is either the Pediatric Lab Utilization Guidance Service, or now we've trademarked the Patient-Centered Lab Utilization Guidance Service because we're doing so much with adults. Too, and its mission is to improve test ordering, retrieval, interpretation, and reimbursement, meaning reimbursement to the patient. Trying to help insurance companies get rid of all the fraud and use that money, instead of for evil, we try to use it for good, which is to pay for medically necessary testing, covered benefits, especially for the worst reimbursed tests, which are genetic tests. So you have kids with rare disease, not getting coverage for very expensive tests. It's a big deal. So that's our four areas that we work in: is insurance advocacy, basic member benefits. We have a national committee for lab stewardship, which I'll talk about, and then case management, which is providing lab genetic counseling remotely for places that can't do it because they don't have a lab genetic counselor. So now there's 85 members to this organization, and ARUP is the biggest sponsor, and they help distribute PLUGS, and they've been a huge help to pediatric facilities all over the country. And we've also gotten a lot of support from Mayo and Prevention Genetics and others, and most of the elite children's hospitals have joined, including yours. And what do you get? As a member, You get all the tips, tricks, policies, procedures. We have member meetings where people share best practices. Sometimes it's simple. Someone will ask, does anybody have a lab genetic counselor job description? And we just post it, or we make it available. Sometimes people say, does anybody have a rational policy for mitochondrial disease testing? And members will share it. And it's really heartening to see people present some of the tricks that they've learned, especially how to communicate with physicians who are angry about stewardship, and most physicians are not. Most physicians, there's been a big change over the last 6 or 7 years where physicians realize they need help and we're there to help them, not there to be critical, because nobody can know all lab tests. When I started, there were only 2 tests. You either tasted the urine or you looked at it in a microscope. Now there's 4,000 tests. And no, I'm not a geneticist. As far as I can tell, they don't even have a naming system. You know, you only have to submit, you change 2 letters, MCA versus MAC, and next thing you know, it's totally wrong. How can anybody do this crazy? You need help. Everybody needs help. So we have, and then you can call in, and we'll workshop stuff with you, office hours, newsletters. There's a lot of contact, and of course there's the Big Plug Summit, which is now the largest, I think the largest test utilization management meeting. We get over 200 members, and it's amazing the kind of people that come. Lab directors, pathologists, lab genetic counselors, and a lot of people from the insurance industry, because what we're seeking from an insurance perspective is alignment. We help them with fraud and abuse, and they agree to cover medically necessary testing. I'll show you a victory on that towards the end of a huge victory towards the end of the talk. So let me talk a little bit about the National Committee for Laboratory Stewardship. The idea here is we took thought leaders from the Plugs Network. So we have a couple from University of Utah or UP. We have University of Michigan, Texas Children's, et cetera. And we are trying to create a checklist that eventually the College of American Pathology might use to show that you're doing stewardship activities in a good way. And then what we're hoping is that insurance companies will recognize that as a seal of approval and gold card certain facilities to not have to do pre-op. And that's not a pipe dream. It's ridiculous, but it can actually be done. Not for all tests, but we're already starting to see some alignment. So just as an example from the National Committee for Stewardship, this is its mission: to improve the quality and value of clinical care through establishing standards for stewardship. And its vision is to just everybody gets the right test at the right time and gets it retrieved and correctly interpreted. And we published the committee published a white paper recently in the Journal of Applied Laboratory Medicine, which goes through stewardship systems in a hospital, how you do them. There's governance, that's the committee structure I talked about. There's the interventions that I talked about, especially the strong ones. The need for data extraction and monitoring, is fundamental to any stewardship program. And then the whole program should be improving and reviewing itself. That's the elements of a stewardship program. And so just as an example, then governance has these types of, actually I'll go right to the checklist. Governance has a bunch of things in the checklist. It would be, do you have a leadership commitment from the chief medical officer or their designee? Is there an accountability structure so that people who are ordering very unusual patterns can be dealt with in a humane and decent way and brought along into the system? Or is there a committee structure, both the committee structure I talked about plus ad hoc committees? Does everybody have a voice? Is the lab represented? Are you part of a network of learning? So that's governance. And these are the kinds of checklist questions that we have in there that we hope to add eventually, get it adopted by various groups that do lab inspections. So that's the National Committee for Laboratory Stewardship. I did want to talk a little bit about insurance advocacy because I think it's one of the most unusual things about plugs. Before most of my career, I just viewed insurance companies as bad people. Just bad. And that's wrong, because my mother taught me a long time ago, and it turns out she's right. I told her this. She's still alive, my mom. There are no bad people, Michael, she'd say. She'd say this about me: you're not a bad person, you're just making bad choices. And so we started engaging heavily with the insurance industry when I was in the adult practice in 2007. And it's really been beneficial just to see what they're up against and to realize that there's a lot of common ground and that most people come to work to do a good job every day, no matter whether you're working in an insurance company or a hospital or anywhere. And so this gives us the foundation for cooperating, where we help each other. And one of the things we try to push is this gold carding, which is it's a concept, but it's the idea that why are we doing pre-auth and choosing the right test inside our system, Seattle Children's, and then pitching it over to one of 10 insurance companies who then make their own set of decisions with their own policies. Why don't we have the same set of policies? And that's been achieved now in a few places for exomes. So what about consensus policy? So this is an example from a member, University of Pittsburgh. This is from the Children's Hospital in a project led by Jody Vento, a lab genetic counselor. And this is really spread. She's really done a wonderful job. We've had her as a speaker at the Plug Summit. But this is her working to get their major payer, Children's of Pittsburgh, to look at their cases and to see that they're only doing exomes for medically necessary testing. They're not doing them for fun or for research. And they're using this collaboration, and she got a lot of help from the chief medical officer at Children's of Pittsburgh. She was able to get her approval rate from 43% to 97% over a couple of years, and has been able to sustain that. So they're essentially gold carded because she has, with this major insurer, because she has shown that they're doing a process that's more rigorous and they're closer to the patient where medicine is practiced. How crazy is it that you're trying to practice medicine and your insurance company's in Minnetonka, Minnesota, and you got to pitch it over there, and then someone comes back who you don't get to know? And insurance companies, they don't want, you think, like you go to insurance companies, the big ones now, the first thing you'll notice if you ever visit them is that there's tons of security and bulletproof glass. Now, do you think, when they started insurance company, they didn't want it to be that way. You think when the first few people got together to form an insurance company, what was the conversation? Probably was like, look, if we pool risk, this could be benefit from everybody, and it could make it so that people don't go bankrupt if they get sick. This could be really great, pooled risk. I mean, they were like, okay, and they're like, okay, you make these policies, you do this, but no one said, oh yeah, and you go out and get the bulletproof glass because for sure we're going to mess this up so much that people are going to hate us that much. Nobody wanted it to be that way. It ended up that way, and so they want to do things like this. They want to build. I'm not saying every person or every company, but in general, people have welcomed this. And we had an opportunity, insurer came to us and asked us to, a third-party benefits manager who services and provides policies to a number of health plans, asked us to write the plugs as a group to write an exome policy. And there was no coverage at the time. Their policy was no coverage for exomes. And we wrote it and they accepted it, and we got about 12 members together from a lot of children's hospitals. And 9 million people are now covered who didn't have coverage, and that should toggle up to around 21 million people over the next 5 years. And I see also that even United Healthcare and these big companies have switched their medical policies to allow coverage. Now they're still putting up administrative barriers, and that's important for you to know about, which is to succeed with insurance companies, they have to have a medical necessity policy. And then they can't put 100 things in the way of realizing that policy. That you got to call this person and you're not allowed to know their last name and your call is being recorded and we're never going to call you back and you can't send us email. Once you put all those, we don't have anybody, we don't have an interpreter, and we're only open for 4 minutes on a Thursday between 10 and 10:04. See, that's the stuff that blocks. So they have to do both. And they're doing it. They can do it. If you help them with fraud and abuse, they can do it. So to conclude, it's good I finished by 8:50, which is what I wanted. Lab stewardship, which is definitely a better name than lab utilization management, improves value. The quality of what the patient gets divided by what they're out of pocket. When the patient can't pay, we pay, and we pay means all patients pay. That's why CBC, instead of being $8, might be $30 in your place. We transfer it onto all the patients. Over the next 10 years, it's absolute that all insurers are going to manage the lab healthcare spend. And so it's good to put stewardship systems as the foundation in hospital systems like Intermountain and Primary, so that you can align with insurance companies and get paid for medically necessary testing. And stronger utilization management or stewardship interventions are structural. As much as I've enjoyed giving this lecture, it's possible that you're not going to learn enough to do anything about stewardship. So you have to use structural. That's a tough part of being an educator, saying that you've spent your life on a weak intervention. But at least we had a nice time. The coffee was good and seemed like a nice group of people. But they're structural, so it's report carding, and it's hard stops and soft stops and CPOE templates and putting genetic counselors or other experts to help. Things like, I didn't talk about diagnostic management teams, but things that help people. They're strong and they're structural. And from our experience, we launched Plugs started with a bunch, 6 children's hospitals, and then now it's 85 members, commercial labs, et cetera, now covering probably 175 hospitals because a lot of the joiners are health systems. And it's been one of the most gratifying things in my whole career because it's so grassroots. We just bootstrapped it, and that's helped stand up stewardship systems and improve relationships with payers. And we're committed to trying to work with payers and to stop calling each other names and to start, trying to help them with fraud and abuse so that they'll pay for medically necessary testing using administrative policies that are not too cumbersome for patients. I want to thank Department of Pediatrics, Ted, and everybody who helped me come out here, and it's been a pleasure to be here, and I'll take your questions at this time. Yeah.
Hi, thanks for that. So I'm an infectious disease doc, and we've been doing stewardship for a long time, and it's great. See, the parallels, one thing I learned from you, I think, is that developing national standards for stewardship may be better than reinventing the wheel locally every time. But I wanted to ask you about infectious disease testing, because it didn't show up on your list of tests that needed stewarding, and yet our experience is that it very much does, particularly with the advent of deep sequencing and metagenomics.
Yes. Infectious disease testing shows up, and we don't have it as a separate category, but I will. First of all, let me back up, and I wanted to tell you that we have patterned the National Committee on Laboratory Stewardship after the antimicrobial stewardship movement, and have had our own antimicrobial stewardship people talk at our Utilization Management Committee meeting, because there's so much that's similar, and we're really thankful for, we even changed the name of our initiative. Infectious disease is not called out as a single category, but we've actually studied it quite a bit, and it shows up in a few domains. In adults, it shows up tremendously in women's health, in over-ordering of unusual molecular testing in infectious disease in the setting of common cervicitis and vaginitis. And in kids, it shows up in a bunch of ways. So that's one place. And then in genetics, when we list genetics, there's a lot of it. Metagenomics is one that's pretty hot now, and it's a good example where I'm starting to get metagenomics requests. And you know what I pitched back to them? The right study. I'm like, if you can develop inclusion criteria, if we can study it, we're willing to use some of our donor money to help fund that and look at it. But you can't just start ordering it. We're not going to be able to, we can't see it on 100 patients a year right now until there's more evidence. So it shows up in over-bundling. It shows up in workup of kids who, come into the hospital and have fever of unknown origin or something that looks infectious, and then there's this shotgunning approach. And it shows up in, now I see it in I know BioFires here, and we use BioFire a lot, but the GI film arrays actually can be problematic. In terms of if it's not, that's a good example where we put that through stewardship committee so that it has straight inclusion criteria. So even though it's not called out, it's a big deal. Over bundling is a big deal in infectious disease ordering. In laboratory testing, infectious disease illustrates a concept that applies for all laboratory testing. Laboratory testing is like a visit from your in-laws. Less is more. Less is more. You can have a good time, keep it constrained. You don't want them moving in. Less is more. A few well-chosen tests is much better for patients in these gigantic mega workups. So I'm glad you asked that about infectious disease. There's some other areas as well, but it definitely shows up, and we have some interventions around that. It comes up in the committee probably twice a month.
So Mike, great job. One question I had on your governance for the lab stewardship, I noticed that there wasn't either IT or decision support. My question would be, do you have someone that has that direct link to someone at IT? And then for the internal database, is that someone on your team that has the analytic skills, et cetera, or do you kind of outsource that to somewhere else in the hospital?
Yeah, it's very important to, so a huge part, well, there's two parts to your question. For the National Committee on Laboratory Stewardship, there's a whole section on data and its importance. It shows up in a number of the different areas, but there's actually a whole section in the white paper on it. In our own group, it's extremely important, and we have our own, they call it knowledge management where I work, but we have our own knowledge management person, and it's important that they're actually employed by the lab. We don't have to keep sending tickets for data. And so we have developed a series of dashboards. You know, our genetic send out, we have dashboards around all send outs, and then and very detailed dashboards around genetic testing. And we actually use some outside, we use mostly our internal Cerner system, but we also use some outside products that are available too. Forget the name of it, Gene Connect is one that we use to manage that. So it's absolutely essential to be able to do basic stuff. The most basic thing is to be able to do a tally over time. I'm blown away by how many labs cannot do a tally over time, which is the foundation of all utilization management. But it's also useful to be able to do sophisticated things. And it's not the most sophisticated, but a sophisticated thing that's really important to do is be able to do report cards. I mean, people behave better if they're getting feedback. And if it's done in a nudging way. And then the other IT piece, of course, is, you know, if you want to get those CPOE templates done, et cetera. So for us, we can do a certain amount ourselves at the local level. Sometimes we have to bring it to hospital stewardship if it's something that's going to make people angry. But then we do have to work it through big hospital IT. And we have a connection with them. We meet with them weekly for about 10 minutes on Tuesday mornings at 7:30. So that's a great question. Instead of talking about IT at this grand rounds, what I did was crack a joke about how bad IT is, and that's wrong. Although it's a funny joke. That flight plan joke, if you want to use it, please use it. But IT is absolutely foundational to any stewardship program. And our IT person, Paul Haraiwa, I should call him out. He's really, really made a huge difference in our stewardship program. Yeah, Jim.
Thank you, Mike, for another excellent talk, pep talk for me. Do you perceive that if this initiative continues the way it is, that the role of pathologists in particular will change going forward?
Yeah, that's a good question. So the question is around the role of pathologists in stewardship. And my answer about the role of pathologists in stewardship is an extremely realistic one. What you hear, when you hear people who are like thought leaders or people who don't work in the lab but are representing the lab industry, they'll say everybody has to become a consultant and work directly with the physicians on everything and go out and start doing these meetings. And some pathologists are just not going to do that, and that's okay. I mean, there's all kinds, pathology is a huge field, and there's all kinds of careers in it. I would say, though, that a subset of pathologists, clinical and anatomic, are going to have to go out, who are suited for it and who want to do this collegial, bridge building, nudging, committee work. It's going to be essential to have a cadre of those who can do those kinds of meetings. And not everybody wants to do that. Some people prefer to, grind out important, life-saving work, concentrating on the workups inside the lab, microscope-based molecular, and that's okay. And we have chemists who mainly just want to do chemistry and make assays. They don't have to become consultants, but a certain fraction of the practice is going to have to do it. But don't force fit people into the role of consultant. I mean, you want to send out people who enjoy it's the coffee donut crowd. Who want to go through these grayer areas. And in our practice, we have a few who do it, and it's great, but I don't force everybody to do it. I think that's a big mistake. There's all kinds of people who work in the lab, and some of them are great at one thing, and some of them are great at others. And so a subset has to be able to do stewardship. So I say that's the biggest difference. You have to have a few. That's a good question.
We should probably wrap up.
All
I
right.
apologize for the drilling. You maybe didn't even notice it.
I didn't.
I noticed
was
these
in the
things.
zone.
It's like
I
when
was
you're
smart.
throwing a party, you notice everything that's wrong. And so sorry about the drilling. Thank you to the Department of Pathology for funding your visit, and thank you, Dr. Astion.